Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of May 6, 2024. As health professionals rooted in Oakland, serving some of the most vulnerable populations in the Bay Area, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID, flu, H5N1, and measles, you will hear from my co-hosts Dominique and Stephanie about asthma, and I'll review a recent article about asthma, COVID, and kids. First off, unfortunately, I need to share that, as you can see here, as of May 1st, hospitals in the United States are no longer required to report COVID-19 hospital admissions, hospital capacity, or hospital occupancy data to the CDC, as they have been pretty much throughout this pandemic. So this is one of the provisions of the Public Health Emergency Declaration that was set to sunset on April 30th, and that is what happened. So this graph that I've been sharing with you every week for quite a while now may no longer be relevant. I say may not because reporting will become optional or voluntary. So sharing will continue for those who so choose. So we'll go from over 6,000 hospitals being required to report this information to we're not sure how many will voluntarily choose to report, but certainly we will expect this to decrease unless another requirement comes to take its place. And in fact, that is currently in the works, thankfully. So this is a proposed rule for the Center for Medicaid and Medicare Services, or CMS. They have proposed that hospitals be required to report not only on COVID, but also on influenza and RSV hospitalizations. They are currently accepting public comment on this matter. And so if this is an area of interest to you, I know it is of interest to me, please consider providing a public comment. There's almost a month left in this comment period, so there's still some time. We'll certainly share resources with you as they become available if this is something that you're interested in. But even if this does take effect, the reporting would not become required until October 1st. So we certainly will have a blind spot as it relates to COVID hospitalizations over the summer. So how will we know what is going on with SARS-CoV-2? Well, as I mentioned before, death and wastewater are the two most reliable indicators that we've had for a while now, actually. Now they more or less seem to be the only two that we really have to see what direction things are heading and to try to understand what's going on in terms of how much SARS-CoV-2 is in our environment and the burden that it is causing. Wastewater is great because it doesn't require anyone to do anything like get tested. It's more a passive system, and as long as we continue to utilize the infrastructure that has been built for this, I think this remains one of our best tools to understand what's going on, not only with SARS-CoV-2, but many other things, some of which I'll talk about today. One of the big challenges I see with this is that coverage of wastewater plants is not very even. So even though there are 1,200 or more sites that are sampled every week, there are whole areas that don't have any sites. So as usual, I'll recommend that if this is something that you're interested in, take a look at the wastewater resources that are linked in the post. See if you can find a facility near you so you can keep an eye on what's going on, either where you are or maybe where you'll be traveling to and so on. And this is something that we'll surely be covering here in more detail going forward since other sources are falling away. The other good thing about wastewater is it is, at least in theory, an early indicator. And we have been seeing a pattern where pretty reliably wastewater goes up, then hospitalizations go up, then deaths. So now we have wastewater, we don't have hospitalizations, we do still have the death data. Nationally, wastewater viral activity level for COVID is considered minimal in all regions. So that is good news. Midwest is slightly higher than the other regions, but really everywhere is considered minimal. And fortunately, right now, deaths are continuing to come down as well. And I do expect this to remain a reliable metric as time goes on. This is one thing we tend to be very good at in the United States, recording births and recording deaths. And even though no metric is perfect, if it says that if it has COVID on the death certificate, then it was the immediate cause or at minimum a contributing cause of death. If it doesn't say COVID, then we won't be as certain because it can be left out or lower down the list, for example. But if it is there, then we know it was a factor. And I don't expect behavior around completing these death certificates to change in any way, despite the other changes regarding requiring reporting hospitalizations. So taking a look at COVID deaths, we had 573 COVID deaths the week ending April 6th, and that is down from 678 the week before. So this is still a lot of people dying every single week. We could be preventing quite a bit of this if we would decrease transmission, especially to those who are at higher risk, if those who are vulnerable stay up to date on their vaccines, and if those at risk of a poor outcome would get timely treatment. So these should be our goals: reduce transmission and ensure appropriate access to vaccination and treatment. Now, this COVID and influenza hospitalization rate graph was updated for the week ending April 27th, showing both COVID and flu hospitalizations are coming down. COVID still more than double influenza in total hospitalizations, a 1.5 compared to 0.7 per 100,000. But reporting for this is also no longer required after April 30th. So this may be the last time I share this graph. Although, again, it will depend on how many hospitals voluntarily report this information, because that will determine how relevant it really is to our discussion here or for us to even bother looking at. So we will certainly be keeping an eye out to see how many hospitals will remain on board with this. We will be advocating for this to become required going forward in the future. But again, that wouldn't start until October 1st. So in either case, we're going to have a little bit of a blind spot over the summertime, most likely. And sequencing of SARS-CoV-2 specimens, so both taken from patients as well as wastewater, is something that I do anticipate will continue and hopefully even broadened or increased. This is something that helps tremendously in terms of trying to stay ahead of what's going on in the pandemic. And as I reported last week, a JN.1 descendant called KP.2 has taken off quickly. It's over 25% of US specimens, likely more than that now. This has not actually been updated on the CDC's tracker. It's only updated every 2 weeks. So this is the same one I showed last week. Remember that we do anticipate a new formulation of a COVID vaccine for the 2024-2025 season to come out this fall. And on May 16th, FDA's advisory committee will have an open session meeting to discuss and make recommendations on the selection of the strain or strains that will be included in that formula. So it will be interesting to see what transpires on May 16th, and we will keep you posted there. In the meantime, should you contract COVID and you're someone at risk of a bad outcome, you should be treated. And the list of who's at risk is longer than you might think, has more conditions than you might think. So if you're not sure, please take a look. That's linked in the post. But if you fall into one of these categories, you should know that now. Make a treatment plan with your physician now. And here are the approved treatments for those at higher risk of a bad outcome. For most people, it is going to be Paxlovid. Your doctor may have to make some medication adjustments for you. So all the more reason to have this conversation ahead of time and get it planned out. If you're someone who cannot have Paxlovid for some reason, then even more reason why you need to have a treatment plan, because the remdesivir can take a little more legwork. Same thing with the high titer convalescent plasma. And really, the molnupiravir is not nearly as effective. It's very much last line, last resort kind of thing. So if that's what's being recommended for you, once again, you really want to have had this conversation with your physician to make sure this is truly the right thing for you. And lastly, we're still waiting to hear about PEMGARDA, the prevention injections for those with immunocompromise. We haven't yet seen it show up on the treatment locator or anywhere else for that matter. So we know that it has emergency use authorization, but we're not certain now, since commercialization of our pandemic response, who's going to buy it, where it's going to be available, who's going to cover it, all of those things that we actually need to know in order to see how we are going to get this to the people who need it. So we will update you just as soon as we know more. Now turning to H5N1, information kind of keeps on trickling in. We've got some preprints, we've got some information, opinions, concerns coming from scientists everywhere, from the World Health Organization and so on. Not going to go into a lot of detail on it today because for the most part, we're in sort of nothing really substantive has changed. I think we're in a wait and see mode. We're certainly concerned about why, for example, it is spreading from cow to cow, mammal to mammal, what that might mean, why that might be happening, how that's happening. So we don't have anything super definitive yet, but at this point, mostly keeping an eye on things, being proactive as much as possible, ensuring that those who need to be protected are protected or have the right guidelines of how to protect themselves. And also hopefully ensuring that we're prepared with vaccines should that become necessary, or who would need to be protected or what that rollout plan would look like. I'm sure all those things are being worked on as we speak. But in terms of what the average person needs to do to protect themselves, I think it remains very doable. So H5N1 protective actions: don't consume raw milk. This includes delicious cheeses that might be made from raw milk. Sorry about that. Although the cheeses that are out now, we really don't know. We don't know when this first really came on the scene. So that's part of the problem. But because of how widespread it is among cows, I think it is safe to assume that it's been around a little longer than we've been talking about it. So err on the side of caution and just don't consume raw milk or anything made with raw milk. Definitely don't touch wild birds. Don't touch any dead animal. We know that H5N1 is making its way into all kinds of different animals. And if the animal's dead, we don't know why. We don't know what disease it has. So that's generally a pretty good idea in general, but just something to keep in mind. Tell the kids. Cook meat thoroughly. Again, generally good advice, but particularly now. If you do work closely with animals, then keep up to date on the CDC guidance. It's actually pretty good, being added to, I would say, frequently. So that link is in the post. But also your industry, if you're a veterinarian or if you work with livestock, your industry standards should be getting updated. So stay up to date with that. And I haven't seen any H5N1 wastewater maps just yet, but there are some folks who've been doing this work of testing wastewater for H5N1. It's giving us some good information. This is very valuable and important work, so we will continue to keep an eye out for that. And now briefly on measles. So just to recap, we hope to maintain measles elimination status in the US, although we're concerned that that is somewhat threatened due to declining vaccination coverage in some areas and higher than expected outbreak activity so far this year in the United States, among other places, including around Europe. The bottom line here is to make sure that you and your children are fully vaccinated. That's 2 doses. If you'll be traveling internationally, it's especially important that not only you get vaccinated, but if you're traveling with an infant between 6 months and 1 year of age, The recommendation may be to get started early for the baby on that MMR series to protect them on the trip. So please do check with your child's pediatrician on that. And I want to briefly point out that there's now a US MPox wastewater data map. This is showing virus detection over the past 4 weeks. Only 4 sites in the whole country have intermittent detection of MPox, so the majority have no detection at all. I'm really mostly pointing this out because, again, I think this is one of the bright spots that has come out of the pandemic, that we have kind of this whole new and improved infrastructure that has really been scaled up during the pandemic. Information is being made available to the public and people working in the field. So this is a good thing, and I hope to see more added to this, more pathogens being added, more sites being added, and knowing that this is just a new way to keep tabs on what's going on in a way that is, again, very passive. It doesn't require anyone to care about it or do anything. It's just in the wastewater, and it's something that we can monitor. So one of the good things that has actually come out of this whole ordeal. And now I am pleased to hand things over to Dominique and Stephanie to talk about asthma. May is Asthma Awareness Month, and May 7th is actually World Asthma Day. So now over to Dominique and Stephanie.
Thank you so much, Dr. Noha, for allowing us to be a part of the People's Briefing today. My name is Dominique Lindsay, and I am the Clinical Program Coordinator for Breathe Oakland.
And hi, my name is Stephanie Echem, a Clinical Program Specialist for the Asthma Program at Risk.
In 2020, Roots Community Health Center started a program called Breathe Oakland. Breathe Oakland was designed to help low-income families. We offer a lot of tools and resources to help our clients to eliminate triggers in their home and in their environment. We work with adults, children of all ages.
We also offer proper use of medication, recognizing and avoiding triggers, maintaining a safe living environment to reduce, eliminate asthma exhibitions, improving asthma outcomes, and offering education. Did you know that Black Americans, Indian, Alaskan, Natives, and Hispanic Californians are more likely to have asthma compared to white Californians? And that in 2021, about 1 in 4 Californians have been diagnosed with asthma. Nearly 1 million cases of children 17 or younger have also had asthma. We also see here the lifetime and current asthma prevalence by race, ethnicity of all ages. Every year, asthma causes 94,000 emergencies, department visits, 9,700 hospitalizations. And because of this, we could also see that 1 in 5 children with asthma miss school and 1 in 9 adults miss work. And this is why we offer these programs to keep kids to go back to school and not miss school, and also so that adults will not miss work, because this could actually affect a family's income when we don't have 2 people or 1 of them at home having an asthma episode.
Here on the chart, you will see a normal airways. In the middle, you will see a little bit of an asthma episode is happening on this chart. When you're having an asthma episode, you will start to experience a little bit of mucus on your lungs, a little bit of chest tightness, and your lungs also will be inflamed. When you're experiencing a severe asthma episode, which is the asthma episode, the picture to the right, you're experiencing a little bit of chest tightness, a little bit of wheezing, coughing, and shortness of breath. Those are some signs of an asthma episode.
Our goal here is to educate families, support our clients, and helping them stay out of the hospital. We also create an asthma action plan, and also to eliminate triggers. Some of the asthma triggers that could happen is the tobacco smoke, outdoor air population, mold, dust, mites, or pests. Also, pets could be a trigger, and cleaning and your disinfectant that have strong smells could also be a trigger for your asthma. And because of these triggers, here at Roots, we offer different benefits to provide clients with supplies. You want to talk about some of the supplies?
Some of the supplies that we provide our clients with are air purifiers, fans, mattress protectors. We also provide our clients with pillowcase protectors, natural cleaning supplies, Swiffers, mops. These are things that we provide our clients with to help to eliminate any triggers that are in your home, whether it's dust, dirt. We also provide our families with house cleaning services. If mold is a challenge in your home, we can also provide our families with mold testing.
We also have during the education for this asthma, we also have the tobacco cessation and tobacco smoke, how we educate families and how secondhand smoke and also smoking directly could affect and also trigger one's asthma. And with all of this, we help to control asthma triggers, improve asthma outcomes, and limit doctor and hospital visits.
We want to thank you so much for tuning in. We are the asthma team, Breathe Oakland at Roots Community Health Center. We really want to make a change in our community. Thank you so much for tuning in.
Thank you for watching. Bye.
Really want to just express my appreciation not only for Dominique and Stephanie joining me on this briefing, but also for the amazing work they do every day with our community to improve asthma outcomes and to really pay close attention to the environment, provide those air filtration units that we know are useful not only for asthma to reduce different irritants and pollutants and dust and so on in the indoor environment, but just to improve indoor air quality overall, which we know is also useful for preventing the spread of infections that are transmitted through the respiratory route. Now, one of the very few nice surprises of this pandemic has to do with COVID and asthma. And what I mean by that is because this virus, when we first identified it, all these respiratory symptoms, we thought it was going to be more like the flu or even the cold in terms of how it might impact people with asthma. We thought people with asthma would be more prone to getting sick, and we thought they would be more prone to bad outcomes. And it turns out that this probably is actually not the case. There have even been some studies that demonstrated that people with asthma may be less likely to get COVID and less likely to suffer a bad outcome, with one very important caveat: if the asthma is well controlled. So for people who have poorly controlled asthma, the opposite is true, as you might expect. They are at risk of a poorer outcome. However, when we look at people with asthma that is well controlled, they actually seem to do pretty well on average. And there's been a number of studies that have actually established that, I think much to surprise of many of us who thought this was going to turn out to be like a number of other viral infections that really can exacerbate asthma and do exacerbate asthma. But why would this be? Why would it be that SARS-CoV-2 would not seem to exacerbate folks with asthma, or why would they not be more susceptible to suffering bad outcomes? Well, as I've reviewed a number of times here, SARS-CoV-2 really is not a respiratory infection. Even though, yes, it is transmitted by the respiratory route, it causes most of its havoc through inflammation, and inflammation that can affect our bodies much differently than flu or the common cold. It can affect a number of different organs in the body. And I've talked about all of these ways that COVID, SARS-CoV-2 is different from influenza in a lot of detail in prior briefings, especially one where I compared COVID to the flu in detail. And the link to that is in the post in case you need it, because unfortunately, we oftentimes find ourselves needing to explain how they're different, because one common narrative is that COVID is the flu, when we know that absolutely it is not. They are two very different viruses. They each need to be respected for their own unique properties and the unique ways in which we therefore have to approach them. And one of the things that I reviewed about the difference between influenza and SARS-CoV-2, it seems to be the same thing that's at play as it relates to COVID and asthma, and that is how they affect or infect human cells. So flu has proteins on the surface that bind to our respiratory epithelial cells, so kind of the cells that line our respiratory tract. While, as we know, COVID's spike proteins bind to our angiotensin converting enzyme 2 or ACE2 receptors, which are on multiple organs throughout the body, including the lungs, but not limited to the lungs. And in people with asthma, they don't seem to have as many of the ACE2 receptors in the respiratory tract. And so they're kind of down regulated, or they're not as ubiquitous as they are in folks who don't have asthma. So that could be part of the reason why. There are a couple of other working theories. I think there's still a lot to learn here. But again, kind of one of those pleasant surprises. And there is one more recent article from just a couple of weeks ago in the American Academy of Pediatrics that looks specifically at COVID-19 and asthma onset in children. I'll just review it briefly. This was a good size study. There were 27,423 patients that were included in the study. And this looked at only at people who had SARS-CoV-2 by PCR. And this was looking at Children's Hospital of Philadelphia, their electronic health records, and it was looking between March 2020 and February 2021. So this was pretty much all a pre-vaccine period of time. We're still getting publications now that are from that far back. Seems like forever ago in pandemic times, but still really valuable research coming out of this, because even in the pre-vaccine time, what they concluded is that being positive for SARS-CoV-2 was not associated with a new asthma diagnosis in children during that observation period. So, of course, we would need to continue to look at them for longer. This is not the same as what we've seen in adults. In fact, I reviewed this in a prior briefing in terms of long COVID and post-COVID, and how we are seeing what looks like a new type of asthma presentation in adults. But this is what they found in children. So this is definitely reassuring. So another piece of relatively good news as it relates to asthma and SARS-CoV-2, and once again, very different than what we know about flu and RSV, for example, which certainly can lead to new diagnoses of asthma. So this was just from one institution. It was just in one time period of the pandemic so far. We definitely need more, but this is something that we'll continue to, I'm sure, learn more about as time goes on. And remember the important caveat I provided about asthma being needing to be well controlled. So we still have too much burden of asthma, emergency department visits, hospitalizations, just like Dominique and Stephanie just reviewed. And we need to do more to intervene to improve. And we really obviously don't want anyone with any underlying conditions to be getting COVID, because as we know, post-COVID and long COVID impacts are real, and we want to avoid all of those. So in order to do that, let's maintain our best practices on preventing the spread of respiratory illnesses. Let's make sure that we're up to date on vaccination, that we are wearing a high quality filtration mask. If you're going to be gathering indoors, Try to gather outdoors, eat outdoors as much as possible, and pay attention to your indoor air quality. Remember that if you do test positive, please isolate until you test negative, because enough virus to detect is enough to infect, and we know we can prevent the spread even within households. Please don't push yourself. Allow yourself the time you need to fully recover. There are studies correlating not resting while sick with COVID to later developing long COVID. And either way, we all deserve time to rest and recover. And if you do not have a primary care provider, please get one. Know how to reach them before you need them. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol, and establish a relationship with your primary care provider. We all deserve to have that healthcare person who we know and who is in our corner. And while you're sick is a terrible time to try to find a primary care doctor. And let's remember to eat a balanced diet, incorporate fresh foods, fruits, vegetables, avoid sugary drinks, avoid processed foods, avoid fast food, get some regular physical activity unless you don't feel well. In that case, please get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you again next Tuesday at 10 a.m.